Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, another iteration of our ShadowBoxing series, where a case is presented to a group of experts, and they respond, but before they do, you're given an opportunity to see what you would do in those circumstances, and then see how it meshes up with the alleged experts on the panel. Before we jump in, and this case is nice and juicy, so I can't wait to jump in. Before we do that, two quick plugs. One, for the Flameproof course. We are now open for cohort 3. And this is the course to make you burnout proof, to protect you from the exigencies of a career in emergency medicine or critical care, to leave you still, as you're driving into shift, completely happy to be going. And if you're worried that that's going to be a problem down the line, take the course. If you are already at the point where you're kind of crispy right now, take the course. Our first two cohorts have loved it. We have honed to the point of, I think, true excellence, the various modules. You could find out all the information and sign up at flameproofcourse.com. That again is flameproofcourse.com. And then just a quick plug for the Reanimate Conference. That's our resuscitative ECMO conference in November of 2024 in San Diego. It sells out every year. So if you're thinking about it, now's the time to book. Otherwise, you may be on the waiting list and not be able to come. And if you're interested in that, just go to reanimateconference.com, reanimateconference.com. So flameproofcourse.com and reanimateconference.com. All right, enough. Let's get into the show. Do it up. Everyone, we are here for another iteration of Boxing in the Shadows. And I am Scott Weingart, ED intensivist, and we will go around. Why don't we go ladies first? Christina.
Hi, I'm Christina Liu. I am an attending physician at Harper Hospital in Connecticut. And I also help run our Emergency Critical Care and Resuscitation Fellowship.
Fantastic. And then the editor of all things Shadows, Ryan Barnacle.
Hi, I'm Ryan Barnacle. I'm up here at Brown, and I'm our director of Emergency Critical Care.
Alexander Bracey.
Hey, I'm Alex Bracey. I'm here at Albany Medical Center. I'm the Resuscitation Emergency Critical Care Fellowship Director and practicing resuscitation.
Fantastic. And then we have two presenters for today's case. Why don't we start with Dominic?
Yeah, so my name is Dominic Nicasio. I'm a new attending, did my residency at Carolinas Medical Center and working in a community ER in Washington State.
Beautiful. And Connor?
Hello, I'm Connor Erickson. I'm from Washington State, Outlook specifically. Did my training out in Sinai Grace in Detroit. And I'm also working with Dominic. I started back in July.
All right. Do it up, Ryan.
All right. I'm going to let Dominic and Connor kind of start us off of the patient's arrival, and then I'll cue us for some pauses to ask questions to the audience.
That was good. So I'll go ahead and start off. So this was a regular overnight shift. Connor and I were both on shift together. So we got different pods in our E. In our higher acuity areas, it's split into the red zone and blue zone. So that night I was a red zone doctor, and I'd just been finishing up a termination of resuscitation call with EMS. And basically, right as I'm hanging up the EMS phone, I see a patient who looks very sick being wheeled around the corner by a nurse who looked frantic, and they paged overhead straight back into room 18. And so at that point, this patient basically was getting set up into our resus room and had the initial swarm of people going into the room. Shortly thereafter, he had his friends trailing in behind him, yelling he's having an allergic reaction. And then first look at this patient, he looked awfully sick. He was very pale appearing. He looked just generally floppy. He was covered in vomit, unresponsive. And so at this point, we're getting him positioned in our bed. We're getting him hooked up on monitors and everything else.
And what was your immediate first move there?
Yeah. So basically, this guy had his friends trailing in, telling us he's having an allergic reaction. This patient looked very, very sick. So I basically had one of the nurses grab some FE out of the med room as we're going in to meet him into the room. And so basically his friend had said that he ate something that he was allergic to. As soon as he's getting on the bed, I can go into his initial exam if you like and tell our initial interventions.
Let's pause there and give the audience a chance to digest this. And basically, we have an incredibly sick appearing patient. We'll get to the details of that. And someone handing us the diagnosis, right? Tentatively, this is an allergic reaction. For the audience and then for our expert panel here, this early in the presentation, is there any downside to an empiric dose of intramuscular epinephrine? And if so, what are the risk benefits? Where are you giving it? What are we doing here?
Should I jump in here? Sorry if I shouldn't, but I'm going to do it anyway. Remind me, do we have any vitals at all in this person? I just think there's an answer to your question, but it helps to know at least that.
Yeah. So at this stage, there was no vital signs. It's basically this guy's like a drop off who looks deathly ill and just went straight back. So at this point, there were no vital signs, just a ill appearing person with his trail behind him.
Yeah. I guess the only thing to ever make, and please, Scott, jump in here, tell me where I'm absolutely misguided. If there ever were to be a thought about should someone get an empiric dose of epi, it would be in the context of somebody who you're concerned about having like severe ACS features or so, or known like 99% occlusion of their left main or something. But I would say even in that scenario, it's quite obvious that they are at risk of dying from the thing in front of them. So I would say the absolute floor is the measure for giving an empiric dose of epi when it comes to somebody looking terrible and says, hey, I just ate a thing I'm not supposed to. So no, I would have absolutely no hesitation whatsoever.
Lou?
I agree with Alex. If all the information you have is that this is an ill-appearing male, he's not answering for himself, and the family says, or the friend said that it's an allergic reaction, I probably wouldn't hesitate to give the epinephrine intramuscularly while we're trying to establish IV.
Yeah, I agree. I would go a step further and say the 2 seconds it takes me to just lay a hand on like the femoral or carotid artery just to see that everything matches up. But the heuristic for me, the reflex, is pericode equals not just IM epi, which I think is fairly benign, but I would probably, if this patient came in by EMS as opposed to the way they came in, just push 50 micrograms of IV epinephrine, which is a much bolder intervention than even the IM, because this guy's just giving you seconds by his appearance. And even if it turned out not to be anaphylaxis, pericode equals immediate support of inotropy and blood pressure. So yeah, I agree with all you. IM certainly is a fairly benign way to go. Even if he was cardiogenic shock, Alex, I think you'd still give that same intervention to a patient who is pericode. Further, I'd be really wary of ignoring the patient, not giving epinephrine to the patient you think might be in the midst of ACS, because anaphylaxis could cause ACS. You know, the Kunis syndrome is vasoconstriction in the coronaries from anaphylaxis. So I don't even think that would be a stop point. I mean, maybe my threshold would be slightly higher in a patient not actively having chest pain symptoms, but they have a known history of coronary disease. But even then, if it's truly anaphylaxis, you just give the epi. So I'm not sure even that would stop us.
Would you take the additional, 10 seconds out if you had it to make it push dose, or to dilute it, that is to say, and make it push dose, or would you just give it?
I think that the heuristic I've been teaching, and I think I stand by it, is you grab the cardiac epinephrine and give half a cc of it. And that is the smallest gradation that is actually on those cardiac vials. And even if it wasn't, you could estimate what half of a cc is, because all of them are marked in ml increments. And if you're a little bit off, a little too little, a little too much, it's fine, because you're going for some middle range of 40 to 80s, fine. And I think the trap that neither of you nor our presenters fell into is, all right, let's just cycle a blood pressure, because that's a path to endless time wasting, because on this patient, the blood pressure won't register. So then you'll hit it again and again. And if so you're waiting for that, you're going to be like really far into a potentially dangerous malperfusion state. So I love the idea of just empirically treating this patient.
Yeah, and I think that's what I wanted to get at for the resident learners, especially because sometimes I still see this like cognitive hesitation to give epinephrine. And even in this scenario where we essentially don't know much at all, there's really no downside in giving it. So that's awesome. Before you guys, can someone clarify, was this an EMS patient or a roll-in?
Rolling.
Wow, okay. We probably don't have IV access. And then I know we keep saying this patient looked horrible, but can somebody from our panel just say, what are we actually looking for at this patient to think anaphylaxis if, say, the diagnosis wasn't handed to us by the best friend?
Do we have a physical exam yet? Maybe just the outward appearance would help bolster what we're going to say next.
We're going to get it, but what are you guys looking for?
Edema, rash, hives.
Oh, I'll go a step further and say LLS score 1, right? If someone was like, they just ate a crab cake and they're allergic to shellfish and they look garbage, that's probably enough to me, because usually it's always, do they have two organ systems involved, and blah, blah, blah. I really doubt that matters. The worse that they look, then you just empirically can say it's probably anaphylaxis.
Yeah, this is one that nicely aligns with the empiric treatment for their problems will also be the proper treatment for the anaphylaxis that you suspect by the history given by the friends. With the only divergence being, if they came in and said, he's been really sick with pneumonia and now he looks like this, you might grab a norepinephrine situation. But I don't even think that would be the right move on this. That's going to take time. So the empiric of, okay, do we need to manage airway and should we just give some epinephrine, will set you on the right path for any patient who, as Alex points out, looks like shit on arrival and you think is at the pericode state, which this patient sounds like. He's already unconscious, he's floppy. Again, I would have immediately just felt the skin and groin and pulse at the same time. That gives me a ton of information that takes less than 2 or 3 seconds. But even without that, you still have, I think, enough indication to empirically treat this patient.
As far as what I'm also looking for, other than that he looks terrible, is that next thing is you say he's covered in vomit, he has a low GCS. I am still also looking at the airway, making sure that if this is anaphylaxis, I want to see, is there a big tongue? Is there any reason that would make him a difficult intubation other than the vomit? And then moving on and then making plans from there.
All right, so you guys got that first dose of Epi in, and then Connor, you arrived at this point?
So Dominic said initially, I was like 2 rooms over taking care of a patient. All of a sudden I hear some commotion. So I get grabbed, I run in there. And Dominic said, this patient's like flaccid, floppy. At this point, I look at him and he has like a diffuse erythematous rash. There's vomit in his mouth, like all over him, really. He just looks pretty cold and clammy when I get up and evaluate him. And he does have some pretty significant swelling of the tongue. He has some, edema there. So that's like the pertinent physical exam right off the bat.
Yeah. So I would say basically, so he got thrown under our stretcher, and with his friends saying he's having an allergic reaction, just like a super cursory exam, just externally, he was unresponsive, vomit in his mouth, clearly not protecting his airway. He had a physical findings of anaphylaxis before any vitals. So that's when he got his initial dose of IM epinephrine. And then we basically got his first set of vitals. And I guess, Ryan, if you're okay if we go into that.
Yeah.
His heart rate was in the 140s, looked at sinus on the monitor. He had a temp of 97.5. His blood pressure was roughly 60/30 when we eventually got it. I think it took 1 or 2 tries. And then his pulse oximetry was reading in the 70s and 80s with the poor waveform, his shock state. And then his respiratory rate, I don't remember the exact number, but somewhere between probably 16 and 20. He was breathing on his own. And then the rest of his exam didn't really show a whole lot. He didn't have any response to noxious stimuli in any 4 extremities. His pupils were 6 millimeters equal-rounded reactive. And he just had physical findings we talked about. He had a swollen tongue, the rash, the urticaria, and that was pretty much it as far as his initial vitals.
All right, let's pause. So we have an altered, shocky, possibly hypoxemic patient with presumed anaphylaxis. What's going to kill this patient first, the shock or his airway? And where should we be concentrating our efforts if we're by ourselves?
Well, I think that what's going to kill him first is like a tough question. I think that maybe thought a different way is, what can I manage now easily while preparing to do the harder thing, which I think we'll probably agree is that the airway sounds scary and dicey here. And I think that giving the cardiovascular support here in the form of peripheral, I'm going to say this is like a really great role for IV continuous infusion of epinephrine as a primary vasopressor. That will probably support, I would guess, fairly easily the hemodynamics while I'm preparing to rapidly take this airway. This is one of the few occasions where I feel like you really don't have that much time to do the airway. And I'm scared just hearing the scenario. So I would be concomitantly addressing the hemodynamics with peripheral vasopressors while pre-oxygenating this person and getting them ready to be intubated.
Yeah, I agree with Alex. And so, I would absolutely, I think this is one of those things where you're doing both at the same time. I would start him on the epi drip because that's the easier thing. And I assume we're going to move on to the airway. And this is one of those patients where, off the bat, that's a scary airway. And that might be someone that, just so to take away your, hesitancy when you need to do it, is someone that maybe you want to just feel out the neck and mark where you would go if this airway doesn't go right.
Yeah, I agree with the sentiments there. I just logistically, I just want to be ironclad about the necessity for immediate action. So the immediate action on this patient for me is I'm going to ask someone to put on a nasal cannula, entitle CO2, and a non-rebreather mask at flush rate, so greater than 50 liters per minute. And while they're doing that, I'm going to place an IO, even if someone's trying to get an IV, and push probably 1 microgram per kilogram of epinephrine, between 50 and 100 micrograms of epinephrine. Now, the EpiDrip's great. It takes a little while to get, and it's going to be my continuous infusion that's going to back up that initial bolus. And even if the EpiDrip was somehow at the bedside right now, I would still be giving a push of epinephrine, IV or IO. And this is really solidified by Ben McKenzie's work in AMAX4. It's just don't overthink it. Just do what the AMAX4 protocol says for the initial stabilization. And it's going to tell you one of the factors is the adrenaline or epinephrine at 1 microgram per kilogram IV push or IO push.
This is, I feel like a topic that comes up a lot is the potential for the dirty EpiDrip. I will say that it's something that I don't usually do, mainly because I think that I can get what I need from giving bolus doses as needed to address someone's hemodynamic instability until the non-dirty EpiDrip arrives. But I don't know. What do you guys think about that?
I guess for me, in my practice, our bags of epinephrine are literally right there in the resuscitation bay. But yeah, I guess you have to do what you have to do. And this could be a scenario for a dirty EpiDrip if you're unable to get it. If you have a shop where you have to get the EpiDrip from pharmacy.
Yeah, this is like a constant debate. And just for the listeners who might not know, the dirty EpiDrip idea is you take 1,000 cc bag of fluid and you put a milligram of epinephrine in, and now you have a drip of 1 microgram per ml. And the idea is just by looking at the flow on a standard IV set, you're going to somehow dial in some reasonable estimation of whatever EpiDrip you want, because you know how many drips per ml there are, and you can know how much 1 microgram per ml in the bag, and you could come up with something. And I've always found this to be the stupidest idea ever. And it's a constant debate with frenemy of the show, Ruben Strayer, because I don't disagree with the quick and dirty creation of a bag of epinephrine at 1 microgram per ml. I think that's great. That's how we do it when we have to make up our own drips. But there's no reason for the dirty component. The dirty component is not that. The dirty component is trying to figure this out as if we were in the 1970s as a paramedic on an ambulance who can't afford IV drip pumps. And that's not any ED in the United States right now. So just mix up the drip immediately, just as you would for a dirty EpiDrip, and put it on a friggin' IV pump. It's just the stupidest thing in the world. And you don't need to have the one where it's already programmed in at the right epinephrine concentration. You just, okay, this is how much I want per minute. So I just multiply that by 60 and I get my drip per hour, which all the pumps are set up for. And even the ones who came back from 30 years ago, they were still set up for that. You need a volume to be infused and you need an mLs per hour, and you'll have a clean epinephrine drip. Yeah, that's why I think that's dumb. But that doesn't obviate the immediate action for me, which is a push of epinephrine. And then the drip could be the continuous infusion that follows that.
All right. Thanks, guys. So, Dominic, you want to talk about what you guys did initially, and then I'll pause again for some more epi questions.
So at this point, we got our first set of vitals with principally his blood pressure, 60/30, and his SATs, 70s, 80s with the poor waveform. So that was, I think, and Connor, feel free to correct me if I'm mistaken, but I think for me, at least personally, that was the scariest part of the case, I think, is seeing, wow, we have two very real ways in which this patient could have a cardiac arrest right now. Is it going to be from or hemodynamic collapse from his blood pressure? Is it going to be asphyxia, bronchospasm, and his hypoxemia? And we're thinking of the best way to manage this. At this point, both nurses, we had 2 nurses on each side going for IV access for, I guess, reasons that we are not too sure. Our IO drill was in the med room and not in the recess room. So before we could even get that into the room, the nurses thankfully actually got IV access on first attempt, which is crucial. But as soon as that blood pressure registered, we had additional IM epi at the bedside. So we gave him an additional dose of IM epi just while the nurses were getting IV access. And we had an ED pharmacist who we asked to go pull an epi drip. And then as we were doing that, I was personally suctioning his airway, kind of positioning his airway. And I put on a non-rebreather and a nasal cannula underneath, both at 15 liters a minute. Because at this point, we're like, this guy clearly looks like he needs to be intubated. If we intubate him now and put him on positive pressure at that blood pressure, I'm pretty sure he'll just code, I think. And either way, it was simultaneous action of getting him pre-oxygenated to the best we can, positioning his airway, giving him additional epi. We just got our IVs, and then we're getting an IV epi drip to the bedside at this point.
All right, so let's pause there. So we've given a couple doses of IM epi. Scott, you're saying that you would give some intravenous or IO push dose epi. What is the trigger to start the infusion? And I want to be like crystal clear for our resident listeners. If you've had an effect with the epi you've already given, when do you need to start the infusion? What are your parameters for that?
Yeah, I'll say a couple things about that, and then we'll hear from Alex and Christina. On sick anaphylaxis, it just should always be managed by an IV drip at this stage of the game, I think, in 2024. That's my belief. Messing around with IM on a truly sick patient, there's no reason for it. You can get the same doses you would get IM with a drip, and now you have complete control over it. That's the barrier to cross is, oh my God, this guy's really sick. And if you really needed something where a guy is decompensating rather than coming in floridly sick like this patient, then it would be a failure of 1 to 2 doses of IM switches you to IV. But on someone who's already super ill, I think you just start with that. And IM's great as a temporizing measure until you get the IV or IO in, so I have no problem with that. But I don't think it obviates the need to then have the drip there as backup. I will say, regardless of whether you feel this airway would be difficult or not, unless things change radically, the progression should be for ultra rapid progression to RSI and then the preparation for surgical airway if that initially fails. Now, the real arbiter of that, because the airway is only going to get worse, is the reason why. It's even though, yes, this might be a difficult airway, they have all this internal mouth swelling, but you still have to progress. The only thing that will keep you from doing that is end tidal. And that, with the understanding that in this case, the waveform of this pulse ox was unreliable. Yeah, you tell me there's chest movement, but that doesn't really equate to alveolar gas exchange. And that's the major mistake is people like, oh yeah, the pulse ox is 80, that's probably okay, but it's like this crappy waveform. Yeah, you have no idea. If the waveform is not pristine, this crisp, beautiful waveform, you cannot rely on it. The numbers just become random numbers. So you can't go on that. Now, if you show me that this patient has true proof of gas exchange with end tidal CO2, and you have them on high FiO2 oxygen, and you never stop at 15 in the United States, always go as high as it goes. 50, 55 is where our flow meters max out. And end tidal CO2, then you have some time. Then you could figure out what should we do? Oh, maybe this is an awake intubation. Maybe we look at this for a couple minutes because they're proving to you that they're exchanging gas and that FiO2 they're getting is the best they're going to do. As long as they're doing even a modicum of gas exchange, then they are pre-oxygenating nicely. So you're buying time. But even in that circumstance, each minute of pre-oxygenation is also a potential minute for increased swelling that's going to make an oral tracheal approach impossible. And you might wind up having to do a surgical airway that you wouldn't have otherwise. So you're really in a fine balance of when to act and err on the side of rapidity rather. What do you have to add to that, Christina or Alex?
Yeah, sorry to keep talking first, Christina. Just feel free to talk over me, and I will go down. I will back down. I totally agree with the things you said. I will add to, I guess, the original question was, what's the trigger for an infusion of epinephrine repressors and epinephrine in this case? And for a practical reason, we already talked about we're going to take this person's airway. At which point we're going to take it. I agree with taking it rapidly, but no matter what time we do it, we're going to take this person's airway overwhelmingly likely. And I think that we should be map pushing a bit for these patients that are going to be intubated, expecting that they'll have some form of hemodynamic collapse. I believe the recent SEC guidelines on airway management seem to tepidly agree with that sentiment, but nonetheless, it is. I aim to shoot for a map of 75 to 80 or so, just anticipating some level of hemodynamic instability post intubation. So even for that niche reason, I would consider doing the infusion of epinephrine. The other thing that I'm thinking about here, when in anticipation of taking the airway, and I just love the point that you made, Scott, that this is, in my mind, one of a very handful of airways that need to be taken now. In the day and age of non-invasive, a lot of things can wait. But these, like a rapidly closing airway is just one of those things. It just cannot wait. And so the plastic does save the day here. I'm wondering if the use of non-invasive to A, pre-oxygenate, and then B, to directly deliver as best you can albuterol and the like while setting up for the airway, if there's utility in that.
Christina, why don't you respond, and then I'll respond to that.
My only concern as far as using a non-invasive in this patient is that he already established that his mouth and everything is full of vomit, which that's one thing is that you're going to run the risk of just driving all that into the lungs and getting into trouble down the line. Although you are so going to the original question, as far as to when to move to IV epinephrine, I agree with Scott. It's how sick the patient is. He's hypotensive. I would have moved just directly to intravenous epinephrine. The person who's awake and talking to you and saying, oh, my throat's getting more swollen, that's the IM epi scenario. And then as far as...
Hey, folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden... and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Taking the airway, you have to move fast, but at the same time, making sure that we go through all the steps. Fast is slow is fast. We're not going to sit on him for an hour and see if anything happens. We're going to take the airway right then and there, but making sure you go through all the additional steps, your pre-oxygenation, your suctioning of the airway. And I said before, having gone down the cricothyrotomy route, it's a very large barrier to get to. You're going to go down, try the oral intubation, move down the line and see. And then if you have to, go to a surgical airway. But this is definitely the one patient where it's a predicted very difficult airway that I would feel it out just so mental wise, you are lowering the barrier to get to the surgical airway.
Yeah. It makes me a little fearful because one of the conversations I had with Ben McKenzie is like, what is the barriers to effective action in these anaphylaxis, severe asthma? And I think it's because we've gotten too comfortable with all of the beautiful methods we have to slow down the entirety of intubation. Everything we've built over the past decade is, no, don't intubate, resuscitate first. Don't intubate, pre-oxygenate perfectly first. Temporize with non-invasive, see what you could do first. That all goes out the window in these cases. Non-invasive is just a stalling mechanism, unfortunately, in these patients because, first of all, if they have any lung involvement, it's going to be ineffective. You need much higher pressures than non-invasive could supply. And as you're doing the non-invasive, this patient's airway is progressing. I think this is the one where you don't do the checklist. You rely on having done the checklist for the past 300 intubations to get you through without it. You don't do an extensive pre-oxygenation. You don't temporize with non-invasive. You just progress to immediate attempt at RSI with a rapidity that belies everything we teach in every other circumstance. This is the one. And that's what came out of these conversations with AMAX4 is that everything we've built and we make our real teaching to our residents and fellows is exactly wrong in this particular case.
All right. So let's figure out what you guys did. Kudos to you. Within 7 minutes, you had an IV epi infusion going at 10 mics. Perfect. And blood pressures got better. But walk us through in detail what you guys did to get ready for intubation, because I think you guys did a really great job.
Thanks. Yeah, basically, so we got the IV epi way faster than I thought we were, first of all. And then after getting both of those doses of IM epi and some fluids on, his repeat blood pressures were systolic in the 70s. And then from that followed to 80s and 90s. And within a few minutes after, up to the hundreds. And during that time, he developed a crisp pulse ox waveform on the 15 liters nasal cannula non-rebreather. His stats were like 97%. We did have him on end-tidal, showed that he was, I think was 30 to 40 or so. And so we had a good waveform at that point. And so I think that kind of took us out of that initial, what was somewhat of a frenzy of, wow, this is really like address his blood pressure, and this is like a crash airway scenario, to he's got end-tidal CO2, his sats look good, he's still unresponsive at this point. And so now at this juncture, with a good pulse ox waveform and his blood pressure improving, we were like, okay, I think we have some time to think about our airway approach, since it doesn't look like imminent threat at this exact moment.
All right, so let's pause there and as the audience, ask yourself, what would have been your plan?
And Connor and I discussed our airway plan, which we were going to use ketamine and rock, have those at bedside, and plan for an awake approach where we would give ketamine about 1 to 1.5 milligrams per kilogram IV over about a minute, keep him breathing. And then we discussed that our plan would be to take a look with a MAC-full video laryngoscope. And if the airway looked completely easy with that, then we would proceed as usual with paralysis. If it looked difficult but obtainable, we would keep the ketamine on board and try intubation without a paralytic. If it looked unobtainable by video laryngoscopy, then we're going to plan to use a flexible endoscope to do a nasotracheal intubation. And basically, if at any point sats were plummeting, we couldn't get them to come up, or if all those approaches had failed, then we would do a surgical airway. As we're gathering all the equipment for a cricothyrotomy, for our flexible endoscope, and for the video laryngoscopy, was palpating neck anatomy and marking the cricothyroid membrane, and just getting everything set up at that point. But I think the crucial point at that stage was that we realized that at this point, or at least we thought, I think we have a little bit of time to think about this, a few minutes, as opposed to just going straight to an RSI, because his stats were improved and he had end-tidal at that point.
And for the group here, what are the risks of a ketamine awake intubation? And is a topical awake even a realistic option when somebody is this sick?
Christina, you want to start with that?
Yeah. So I think one of the risks of doing a ketamine awake intubation is that, especially if you're using any sort of video method, that you're very easily going to get your view blocked if the patient still is vomiting. The other thing being that it's very, I guess you were talking about time. I guess in this case, you thought he settled out a little bit. For me, when I think of it, if there's vomit, I'm already jumping to more of an RSI situation. But just because, especially with the little bronchoscopes, those cameras, just one tiny dab and your whole view is out. And I probably don't want to go mucking around in there.
Yeah, I think fiber optic for me is not an option given the things that we've spoken about already. I wonder, to answer your question about topicalization only, I've probably been doing it wrong for every instance that I've tried to do this in my career, but I've had very limited success, I would say, with just doing topicalization, no additional sedative. I just can't seem to get people to a place that they tolerate anything. And so I almost always have ketamine as a facilitator there. I wonder in this scenario, and this might be it's possible, but if I were going, I think I probably would have done a RSI, or I would have given a sedative and taken a look and then pushed paralytic, depending upon my ability to open or get a view. And part of me is thinking that I might have done that with a hyperangulated blade, but also the vomitus and the potential to need to switch to, I think I probably would have tried with a hyperangulated. I'm just going to throw it out there. Sorry to everyone who thinks otherwise. The other issue that I'm wondering about is in that instance where I'm giving a sedative, if the ketamine might make things too hypersalivatory, and I would tominate being a reasonable alternative, I think, without that side effect. I think I might have tried that just for that potential downside of ketamine. I wonder what you guys think, though.
Okay, so yeah, a few things have been mentioned. Now, before I talk about topicalization versus ketamine awake, let's just say that what we have now moved to, because of the patient's progression, is a very gray zone now. We're out of the standard AMAX4 protocol, because now we have had a patient who's hemodynamically stabilized. So that's off the table. They look much better in that regard. We actually have end-tidal on the patient, which is rare in most EDs to have non-intubated end-tidal, proving the patient's doing gas exchange, and the patient's satting well. So now we're in a kind of a situation not clearly discussed. Now, if you just apply the AMAX4 protocol even with this patient and just progress to intubation, I don't think you'd be in a bad practice pattern, and that would, be an RSI intubation. But if you are in a site that is more savvy, to resuscitation and critical care do have some options opening. And now maybe we can take the time to do an awake intubation. But I'll just say, you're diverging from what is, I think, a very good set of reflex actions. By doing that, you are opening yourself up to, if it goes horribly, why did you do that? Why did you not just progress with the rapid sequence intubation that is indicated by the most current and I think evidence-based guidelines? So I'll just say that if you're doing this, you're taking that responsibility on yourself to say, like, I am not worse than the reflex actions. I think I am a little bit more savvy or capable due to the increased aggressiveness of our center is what you're really saying. So you better be able to justify that. Would I do topicalized intubation on this patient? No. I think just from a timing perspective, if I'm going to try an awake look, it's going to be with ketamine. The hypersalivatory issue doesn't really faze me. It's easily suctioned, especially if you're using a video laryngoscopy awake technique, which I think is probably the right way to go on this patient. And now, if you're doing titrated doses of ketamine, as opposed to just pushing empirically 1.5 to 2 milligram dose, if you're doing what I do, which is give 0.5 and see, then the hypersalivation is a dose-dependent response. So I think you could get away with it. And if there, you're just going to have a decanto suction in your hand. It's not a big deal if they have spit. The vomiting is the problem, right? Now, in a patient who had a GI bleed or something like that, I'd place an NG tube. Is that the best idea in this patient? No, I don't think. I'd probably just progress with the intubation. And then the question of what to use. Alex, I like your idea of hyperangulated from a visualization standpoint, but I would put to you that you're now losing all the advantages of a bougie in a patient with potentially really swollen glottis. Now you're going to have to force in a styleted endotracheal tube through that, while the ability of a bougie to actually be continuously turned into that horrible swollen edematous glottis until you finally pop through, and then using that as a pathway for your ET tube often, to me, has many advantages. Now, obviously, if you have a manipulable tip bougie, like the Sharn anesthesia ones, I think is the only ones available in the United States right now, which is the only reason I mentioned the brand name, then you have the best of both worlds, and you could certainly use hyperangulated and a bougie. But even in that circumstance, the Sharns don't really push through things as well. They have a tendency to curl up on themselves. The traditional horrible blue bougies might be, I think, the ideal way to go in these patients.
All right, less than 15 minutes in, you guys really turned this patient around, but we're ready to take his airway. Why don't you walk us through the next few minutes? Because you guys were able to mobilize some help quickly too.
Yeah, Connor, do you want to go through some of the stuff we did after that?
Yeah, sure. But at this point, as a backup, predicting a potential airway catastrophe, we contact ICU to have them come down since patients want ICU regardless. And secondly, we paged out anesthesia because at this point, we can't find our fiber optic scope. Like we weren't able to find it. You bring down some supplies anyway. At this point, he's already pre-oxygenated, everything like Dominic said. I'm at the head of the bed getting ready to potentially intubate. And then almost like by the hand of God, he just like wakes up and starts talking, like his swelling is like already subsiding, his rash is like fading, and he looks absolutely amazing. And then as soon as that happens, it's funny now in hindsight, ICU and anesthesia show up to the bedside. They're like, so what's the problem? Like, are you going to intubate him? I'm like, within the last 15 seconds, he's going to be like miraculous recovery. And you don't realize like how close to like imminent death he appeared like moments ago. Oh, okay. They're standing there just smiling at us. What are these cowboys doing here? So at that point, like everyone started to feel a bit better. And then at that point, we're just watching him. He's still on the epinephrine drip. Eventually we start to titrate it down a little bit, but at that point, he's saying like 98, 99%. Blood pressure's great. He's alert, talking like, hey, what happened? He started to tell us, I have a nut allergy and I took some Nutella, I think is what it was or something. He just looks like a completely different person at that point. So at that point, he's not vomiting anymore. He looks completely better, not completely better, but it's 95% better in the moment of right after paging them to when the specialist got to the bedside. Now they're snickering at us.
Yeah, it was really strange. Like he eventually had admitted to, or his friends had told us that he had been drinking some alcohol or whatnot earlier in the night. So I think that probably played a part in it, but I think also just his profound hypotension and just, I think why was not perfusing his brain was like the best thing I could come up with, where White was completely unresponsive to basically looking like he was just waking up from a nap and then started talking with us again.
This guy was truly peri-death. The alcohol doesn't need to be there. This was a patient who was about to code, and given the time course, you guys just turned him around with the aggressive administration of epinephrine. So the case makes complete sense. It's just the message I don't want people to take is, So we could just observe a lot of these guys and avoid having to progress to a really scary airway. And just given the timing, I hear you guys, and you've managed this case wonderfully. I would make an argument that the take-home message I would like to see is as soon as this patient's blood pressure stabilized, but he was still unresponsive, a rapid progression to airway management probably would be the move that's going to send you the right direction 9 times out of 10. And I think this case, you were just lucky enough that this was the 1 out of 10 where it turned around soon enough to stave off intubation.
There's another message that I think is highlighted so neatly by this, which is that I constantly, and we see and are taught that ABCs, it was so rigid, ABCs can't progress to B before passing A, at least mentally. And certainly we were addressing that, or you all addressed that while you were progressing through the ABCs to circulation, which you can do all these things all at the same time, I feel like, the first and foremost, and you did well. And in so doing, you prepared C first for in anticipation of doing A safely. And so I just think that highlights the message that despite it being very easy and easy utterance and easy to remember because it is the alphabet, oftentimes A does not need to be addressed in a definitive way, quote unquote, with a tube prior to addressing especially circulation. And it makes everything else much safer to do those things in concert.
I was going to say, this was a great case in that this seems like it's very straightforward. Yeah, anaphylaxis, deal with every day. But as you can see, there's so many decision points along the way and everyone has a little bit of a different approach to it and different styles.
So I think I have 2 more questions for you guys, and then I'm done. Maybe the presenters have a couple more, but let's say he got better as he did, but he's not awake yet. And you guys ended up having to transfer him because there was no ICU beds available. If he's doing better, but you have to transfer him, is that a reason to intubate them?
It's funny. I'm going to take it a slightly different direction. And I don't know if this patient needed to be transferred, just given the way anaphylaxis usually plays out. I think he probably could have gone to a step down or maybe even just a monitored bed because the whole rebound phenomenon, not all that real. And if it does occur, this patient just needs probably IM epinephrine at the beginning of his recurrence. Just because this was horrible at the beginning, I certainly wouldn't send this patient home, though you probably would have gotten away with it if you did. But yeah, I don't know if he still needs transfer. What's the indication for ICU admission and therefore the necessity of transfer is what I'd ask our speakers.
I get what you're saying. I realize that. Yeah, complete recovery and with the anaphylactic, the nature of the episode, that he should be getting better. In my mind, I was just looking in hindsight from a case review perspective. Like, this patient were to decline on the floor, he's peri-death on arrival. Did you consult ICU? What did ICU want to do? We didn't have any ICU beds available. And given as a new attendee, this patient was essentially peri-arrest on arrival. I thought I would err on the side of caution, just keep him in the ICU for 24 hours, and they could always drop him to step down or to the floor. So I conveyed that to the patient and his mother. We watched him for probably another 2 hours in the emergency department. He's epi-drip down to 3 mics a minute. He's GCS 15. It looked completely better. He got the antihistamine cocktail, steroid cocktail, all of that. Initially, they wanted to go home. They said, let's just keep you here for a couple more hours at least, trying to buy time for them to change their mind. Ultimately, we were able, I spoke to a tertiary center several hours down the road. And so we transferred him there. The question was impending airway catastrophe, doesn't need to be intubated. And from my perspective, for the next several hours of close monitoring, he had no airway compromise, no stridor, no recurrent angioedema, nothing. And at this point, given the potential risks and benefits, I didn't think he needed to be intubated. I just wanted him to further the trip. So given that we had 2 hours of close monitoring, I didn't think we needed to address the airway.
I think, Ryan, your question, it might have also included the possibility if he had not improved in terms of mental status. If that's, I think that makes it easier. If that was your question, I definitely would intubate that person prior to transfer. But I think I would not do anything differently than what was described in terms of not intubating them, especially in monitoring, insofar as he got better.
Yeah, just for the audience, he's still on epinephrine. Most hospitals, I think he needs to go to an ICU.
Yeah, that certainly. And I did not know that was the case, but I would say, does he need to be on epinephrine? What is the indication for why this patient was still on epinephrine at this point?
Blood pressure, right?
His blood pressure was in the, I'd say 110, 115 with the 3 mics of epi. So I just didn't really feel comfortable shutting it off. Could we have probably done that? Then IM PRN, probably. But in my case, I was like, look, he's responding to this. He's looking better now. Let's just leave it status quo. That was the best explanation I had at that time.
Yeah, that gives you a perfect justification to put him in the ICU. I think, and that makes Dispo easier. I think you probably, at 3 mics, could turn off epi and see, because you could always turn it back on. And I think what you would have seen is his blood pressure probably would have stayed the same.
So we spent a lot of time talking about epi. Just to wrap things up, are we giving him all the other meds? And if so, what meds? And specifically, would we give glucagon for a patient on a beta blocker, for example? I've never really done that in this situation, but I came across that when I was reviewing things.
I think all he really needed was the epinephrine, but my practice is I would have given him the steroids as well, just for long term. He didn't need it emergently, but now that you've pseudo made him improve and he got past the emergent parts, yeah, I would give him the Solumedrol and whatever it comes with, the famotidine, maybe Benadryl.
Yeah, I think you do all the adjunctive stuff. I think, and the question, a question might be like, does a certain kind of steroid make a difference? Dexamethasone versus methylprednisolone, right? I think I'd probably do dealer's choice on that. And my current place happens to be dexamethasone for everything, so probably that. And I think I would keep everything at this point, given that he had anaphylaxis, including probably like gut, which maybe makes it so that absorption gut-wise is not as adequate, at least for a period of time. And I might be overthinking that again, but otherwise, with a much less severe version of this, rather than giving Benadryl, I typically give cetirizine now, or Zyrtec, or whatever non-trade name, the second generation antihistamine, just so it has a longer duration of action and doesn't make people sleepy and then send them home. But yeah, I give all the adjunctive stuff, but I don't know that I would. I think as far as glucagon goes, this person's already vomited, and I think that's a pretty predictable side effect from glucagon, so I probably would not.
Yeah, I agree with most of that. The Benadryl is the one I'd probably think twice about because of the exact reason Alex just said. This is the guy I do not want to make drowsy. If I think he could take PO, then I'd just pop in one of the second generation antihistamines. If not, then I'm fine just ignoring it entirely because I don't think they do anything. And I don't think the gastric stuff does anything significant either. Epinephrine is the solution to all of this. I'd give the steroids even though we have no idea if it works. The glucagon I would give if they were intubated for the exact reason that Alex mentioned, because I'm not going to give this patient without an airway something that's going to make him very likely to vomit. So yeah, if he was on beta blockers and the tube was already in, then you could consider glucagon without great evidence behind it. But otherwise, I'd probably stay away from it.
Gentlemen, that was an excellent case. You guys really saved his life. It's almost as if you've listened to EMCrit before, I must say. Do you guys have any other questions before we sign off?
First of all, thank you for having us. This was awesome. Been listening to EMCrit for quite some time. I've always loved the ShadowBoxing thing. I think one question I had was just like contingency planning in that initial set of vitals that we had. If he has a cardiac arrest right now, what is the first action during that code that we run? What actually killed him? I guess a lot of things that you say would run in parallel. You'd be getting the code dose epi while you're trying to secure a definitive airway. But I guess a lot of it for me was just that contingency planning up front when his sats were, who knows where they're at with it being 70 to 80 with poor waveform, his blood pressure's in the toilet. And if the sat number continued to fall, but with the bad waveform, what does that mean? Does that change your immediate action plan? If he codes, what's the next immediate step? I think were some of the questions I had, but.
Yeah, I'm going to reiterate. If the patient came in the way they came in and you just wanted to do the action that over the course of many cases across the world, the actions that would save the most lives, I think it's an immediate provision of a high dose of epinephrine through some route that's going to get into the intravenous space, and then an immediate push of a paralytic and RSI attempt. And I don't care if the sedative there or not with this guy who's unconscious. And if one attempt fails, a cricothyrotomy. And just because of case progression, you guys did not have to go down that road. And I think every choice you made makes complete sense. But I'd like the reflex that is built into people's minds that when a patient like this comes in, it's hey, push epinephrine, 100 micrograms while I am intubating. Even without pre-oxygenation, this patient's not going to die of an oxygenation death. They're going to die of an airway death. And so if that's people's reflex and then they divert from it with the knowledge that I'm diverting from a reflex that is going to potentially save the most lives, that's fine. But if on the other hand, it's just a feeling inside people's heads, wow, oh, man, I don't want to do this. Let's see what we could get in the next few minutes to avoid having to go down that path. Then that's the reflex you have to stamp out real hard.
That's all I got, everybody.
That's fantastic. Great job, guys. Great job presenting.
Awesome,
Great job
Jason.
taking care of them. And yeah, we hit it an hour. This is the perfect timing for shadowboxing too. So this is where we should hit on future iterations. All right. Anyone want to add anything else?
Thank you for having us. It's an honor to be on your podcast.
Pleasure. All right. Thank you to all the participants. Thank you to our panel of experts. Thank you, Ryan, for getting this all set up and putting in the legwork to make this happen. And folks out there, keep on listening. If you have questions, put them in the comments and we will be sure to answer. This has been Scott Weingart for all my guests saying bye-bye. But of course, before I officially say goodbye, I just always plug the medicine coaching. That's my physician performance coaching service. And if you're interested in getting coaching to take a career that is in the doldrums and make it better, or if you're already a high performer but want to get that additional 1% and just make yourself even better, then just go on over to EMCrit.org/coaching, EMCrit.org/coaching, and we'll get you all set up. We'll talk. We'll have a free chemistry call. We'll figure out if I can help you. And with that, I will bid you all adieu and speak to you very soon.